So we've talked about the agenda, but really what I would say is that cranial ultrasound is essentially a scan that's performed through o- open fontanelles. The word is open. And the reason I say open at this particular point is because what you'll find is there are a large number of babies who have very small fontanelles. There are a large number of babies who have problems with their with hair. And I've just done a scan on Friday where really I really struggled with the quality of my images for what was a very important scan. And it was just because the baby had so much hair, it was really challenging even with gel to get the best windows. I think the key thing from our perspective when we talk about performing a scan is making sure that we make the best use of the open fontanelle and that our probe is placed in the best position to be able to get the maximum width, the maximum delineation of the neonatal brain. We already have discussed the importance of using cranial ultrasound, not just to detect brain anomalies, but for preterm screening of intraventricular hemorrhage, and in particular for guiding treatment decisions, not just around this, but around a lot of other conditions. We monitor preterm infants usually by performing scans with schedules that have been described by Dr. Amen in the last lecture. But more importantly, cranial ultrasound is increasingly becoming what I would say is a guiding tool for making management decisions. And a very good example is really when we plan to treat hydrocephalus, we work out VIs, we look at the baby clinically, and in that situation, we then decide therapeutic intervention based on that. I think what I'd say is that what we've got to be careful about is when we choose a particular neuroimaging technique in a neonate, we've got to understand that there is a limitation, not just from the fontanelle, but actually from the baby's clinical condition as well. And it may not always be possible because the baby might not be stable for us to do a lot of handling to be able to get good image. But more importantly, there are certain neuroimaging procedures that might give us better and more appropriate information that we are looking for. And for units who now have MRI on the neonatal unit, where they can take babies for that, we very much know that MRI is a very important aspect in the management of babies with HIE, to the point where people are actually starting to do early MRIs, even in cool babies, to try and look at SWI and DWI and trying to make not just diagnostic, but actually therapeutic kind of decision making. At the end of the day, what I'd say is that whenever you're using cranial ultrasound, you have to do it as a procedure through the fontanelle. And as I'm highlighting at this particular point, you have to have a baby who is comfortable. You have to be comfortable with your procedure. I cannot emphasize this enough. If you're not comfortable and if you're doing a procedure for a baby in a cot arched with your back, you're not going to get good quality images. But more importantly, that will encourage you to try and complete the scan in a hurry, which often results in suboptimal images. When we look at the actual procedure, it is traditionally performed through the anterior fontanelle. So the anterior fontanelle, as is described, I'm just going to annotate for those of you who are completely unfamiliar with the fontanelles. I doubt very much any of you are. So this basically is the anterior fontanelle, and all the coronal and sagittal views are taken through the anterior fontanelle. We often will start with a protocol that encourages us to actually try and obtain midline and then proceed from there. But there are some advantages in being able to use the other fontanelles. Uh, I rarely use the posterior fontanelle unless the anterior fontanelle is small, and I feel that I'm actually going to get better quality images of the back of the brain, in particular, both the trigonal region as well as the cerebral hemispheres at the back. But it is beneficial for actually being able to view the trigonal region, and we'll talk about that. I think what I would say is that for viewing the cerebellum, the use of the mastoid fontanelle, as well as using using the temporal window to be able to view, I would say, the ventricular system and look at the site of blockage, communication between the third and the fourth ventricle. It's really useful to have the temporal fontanelles. But amalgamation of all of these views then basically results in what we call is an enhanced scan. And an enhanced scan is quite detailed, quite long, and is not necessary for every baby. So the procedure itself really depends on the clinical indication and depends on what local protocols you have developed. Now, can I, with a show, just you can all speak out hopefully one by one. Do you all have guidelines for cranial ultrasound in your institute that you follow for the protocol? Does anybody not have a guideline? Can they just write in the box? So, as part of our talk today, we'll be sharing this presentation with you, as well as an aid memoir about the steps, not just for performing cranial ultrasound. So we call it 10 steps. And there are 10 steps in performing cranial ultrasound, and there are 10 steps in interpreting cranial ultrasound. And there are two PDF aid memoirs that I will share with you that you can keep at the back of your pocket, literally on your cell phone, to be able to open up. You can print them. It's quite easy to laminate them as sheets. And really, what they help you do is follow those steps while you're becoming more confident in being able to obtain the images. But even for interpretation, it can be quite challenging for somebody who's not done cranial ultrasound when he looks at the image to kind of say, well, where do I start? There's so much to see over here. So again, we've got an aid memoir that works on that, and that'll be part of one of our sessions coming up. We've talked about clinical indications and patient selection already. A slide problem moving my slides when it goes to recording. Now, in terms of equipment and subject, you need to have an ultrasound machine. And what we're going to talk a little bit about before we talk about the actual imaging process is knobology. You naturally need to have the baby, and the baby needs to be comfortable. And clearly, what you can see here is a baby who's completely comfortable with pressure and touch, who looks pretty easy in terms of being able to scan at this particular point. But I'm just talking about height over here. Can you see the height in relation to hands? Now, if this is a very tall person and they want to do a scan in this baby, it can be a real challenge. Foremost, we're going to talk about the machine first and preparation for the procedure. So most machines these days are modern machines, and they usually have multiple probes. And the most common probe that you use is the curvilinear probe. And you will usually, in term and preterm neonates, near term neonates, I would say babies above 32 weeks kind of default to 7.5 to 8 hertz. However, in bigger babies, in particular infants, you may, in order to get the proper depth and quality of imaging, need to actually reduce frequencies even as low as 5 hertz. And again, for babies, say, for example, who are extremely preterm, you might have to increase those frequencies to 10. I note Eamon mentioned going up to 15, which is really needed when you're looking at the meninges or blood vessels, very superficial layers of the brain. Not all machines will be able to do that. And really, what you really need is a linear probe for that. Now, on this machine, which is basically a GE, which is what we use on my unit, we have a curvilinear probe, a sector probe that you can see over here. And again, I'm just going to annotate. So this is an example of an abdominal curvilinear probe, which usually operates with a frequency of up to about 5. So it's being used in what is an infant, a baby who's a few months old. And naturally, the lower frequency is being used so that you can get good quality images with adequate penetration, with, I would say, a frequency that will give us acceptable images. We all know that lower frequencies might not give us as good images as higher frequencies. We discussed that in the first lecture. On the other hand, what you also have is a linear probe if you want to see meninges, and a linear probe will give you frequencies well up to 15. So if you really want to focus on the more superficial areas of the brain, this is an option. And then you've basically got what I would say is the sector or the convex probe. And you can't see the convex probe over here, but I will show it to you. Now, at the end, when we use the ultrasound machine, what we're basically doing is using the gel and the acoustic interface with the organ to give you a high quality image on screen. These images, basically, as we know with the properties of sound, are producing uh, an image which the machine translates into a picture. And what is very important is that you then capture this picture in the ultrasound machine and help store it on a drive. And we'll talk about that later. But for the parts of the ultrasound machine, you have certain buttons. Now, as a the first step usually when you're actually using your ultrasound machine is basically turning the buttons on and off. And That, I would say, is something that if you're using a new machine and have never used it before, can actually be quite confusing. But most machines will give you an on and off button. They will then let you fill in patient details. Now, there might be a patient marker that allows you to do it. In our GE, actually, we have to go to the actual screen and enter the patient details by clicking on patient. Once we've entered patient details with at least, I would say in our setup, we need to enter patient name, sex, gestation, weight, and actually an MRN number. And those five kind of details basically give us the necessary details to be able to save those patient identifiable features and images under them. Once we've done that, we then basically select our transducer. And here you can see a chest ultrasound being done with the linear transducer, but you can select a transducer by going to what is called either a preset or by selecting the transducer and altering the frequency, depth, as well as the focus manually. And these, I would say, are the three most important buttons on your machine. So as we go up, this is what any standard ultrasound machine will look like. It will have a button for frequency. Now, if you select a preset, and a preset might mean that in a term neonate, you're selecting a depth of 7 centimeters with a preset frequency of 7.5 or 8, with a focus that is usually kept if you're doing a coronal image at the level of the corpus callosum in the midline. So that preset from our perspective is already set to run. Your gain settings will be pre-selected, and some machines like the GE has basically what we call an auto gain function. And an auto gain function basically means that you can press, and you can see this button over here. So not by turning the knob of the gain, you can actually turn the brightness of the image as it's described up and down to get the adequate resolution, or you can just press the button. It's called auto over there. And really what it does is once you've put the probe on the baby's head with gel, it will automatically adjust your gain settings. Now, just remember that when you use the GE machine or the Sonosite machine, you should press it twice. And the reason is when you take a probe with gel and you put it on the baby, and let's say we put it on the baby's head, then what some machines are automatically set to do is try and use the preset gain settings as you would like. But more importantly, when you press auto gain, they will adjust the settings from the original presets, and you might have to press the button again to get appropriate gain. However, if you want to set things manually, then what you might be able to do is just select your transducer. And a good example is if we're using the convex, which is usually a C85, which kind of indicates a frequency of 5 to 8, then I will preset, rather than using a preset, I will select transducer, and this transducer will basically select the C85, but it will allow me to then select the frequency between 5 and 8 in three quadrants. So you have centiles of 25, 50, and 75 to 100, which kind of means the maximum frequency that I can select is 8. There will be an in-between frequency that might actually be 6, and maybe a frequency that defaults back to 4 on this. And you can adjust the frequencies to be able to be in between this. Or alternatively, you might have a button that you can turn to get the exact frequency. Now, in our GE machine, unfortunately, we don't have that button. We have quadrants which basically look at the centiles for frequency and get you close to the frequency that you really need if you're using the manual mode. But experience sets that once you've set the frequency, the next step is basically setting your depth. And in term babies, we normally set depth to about 7 centimeters. But in preterm babies, you'll need to adjust. And an extremely preterm 400-gram baby may actually not just need adjustment of depth, but actually may need a little bit of magnification as well, because actually you have a large curvilinear probe. And when you put that curvilinear probe on the baby's head on a very small fontanelle, it's looking at a very small area of the brain. But the depth in a preterm baby may have to actually be reduced a little bit, maybe 3 or 4 centimeters, with a little bit of magnification to actually get adequate resolution. And we'll talk a little bit more about that. Once you've done that, you then have to adjust the gain setting. And as you can see over here in this machine, you've got basically a B and a M, which basically means auto setting. So you can either press that or you can turn the gain up. The challenge from our perspective is when you turn the gain up, it turns the gain up for the whole image. It doesn't necessarily adjust gain in individual quadrants. And that is really important because that function is fulfilled by a function which we call time gain compensation. And I will talk about that a little bit more towards the latter part of this lecture. You also have a focus button. And a focus button, from our perspective, is not present in pre-modern machines. So at the moment, we don't need a focus in the GE, we don't need a focus in the Sonosite. And really, what I'd say is even in the Philips, you don't need focus buttons. And the reason for that is because the probe tends to automatically adjust and optimize focus at each focal point uh, whilst you move the transducer back and forth. So it produces the best focus for that range. And in those situations, really, if you really want to optimize your image, the ways to do that would be by changing frequency instead. And that depends on the depth at which you're really looking for the image. So you might have to alter those buttons instead of having a focus. But if you have a focus button, then really the focus button is usually when you start in coronal plane, placed at the level of the corpus callosum or the ventricular system. And in the sagittal views, what we normally say is we like it placed at the level of the ventricles. And that will give you reasonable resolution to be able to see both superficial and deep structures with the same probe used in both coronal and sagittal planes by keeping the focus at the level of the ventricular system. If you feel that you want to see meninges in the more superficial areas, then you can change the focus to the more superficial region, and that will basically change your marker and screen, and I will show you that. But it might be better for you to use a linear probe with a higher frequency to be actually able to do that. Any questions about buttons? So we've talked about frequency, depth, focus, and gain. I'm not covering time gain compensation just yet. I will cover it when I cover advanced ultrasound physics. But any questions? Feel free to unmute yourselves. Feel free to talk over each other.
Sir, what is gain? So, if we increase or decrease gain, what is that?
I'll talk about that. So when I
Okay,
do
okay,
advanced physics, I'll talk about that. But in
okay, okay.
essence, what it's doing is it's increasing the brightness of your image. So from our perspective, what we're really doing when we're kind of adjusting the gain, as you can see here, is we're improving the brightness of the image. Sometimes what you find is that you have a lot of hair, and when you have a lot of hair, we talked about the concept of reflection. Let me come to the next slide actually, and it'll be easier for me to explain to you. Any other questions? Okay, so for everyone who has never used or touched a probe in an ultrasound machine, the steps we'll talk about, but you need to know the frequency button. You need to know depth and gain. You need to know about time gain compensation. And for those of you who've got a focus button, you need to be able to know where the focus button is. First step is turning off and on, letting the machine boot. Always wait for the machine to boot, and machines should always be booted plugged in. If your machine is not plugged in, you're in big trouble because you might have a battery that's 10%. And really, can I just warn you that when you press the on button and the machine crashes because it has no battery, there's a real risk that your motherboard will actually short circuit. So please, always when you're using the machine, don't leave it on battery. Never use a machine on battery. Always connected. Most modern machines are set to work only when you really connect them to an electricity source. But there are some machines that you can disconnect and continue to perform ultrasounds. And if your battery is low and you lose images, it's just, it's a wasted exercise. Remember to always put in patient details correctly. Choose the right transducer or preset. Now, this is a preset button, which basically looks at and will give you different presets. It'll give you a preset for the brain, lung, heart, and you can really then choose exactly what you want. For those of you who don't have presets, again, I will share a video with you of how you can set presets on the GE. Depending on what machines you have, if you want to make up presets, it's really important that you have a very good relationship with your engineers. And I would say that this is a really good opportunity during this course to basically get presets made for your machine based on what we're going to discuss in this and in peer review so that you can actually make it much easier for you to start using the machine. We have depth, we've talked about focus. Obviously, once an image is captured, you capture it after you freeze images. Some people like to do loops. In our protocol, what we normally do is we will always take still images after freezing them. But for Dopplers, and in particular, if we want to see any vascular elements or any areas of the brain we want a radiologist to see because we're slightly confused, we will always take dynamic loops because then they can see in dynamic view with the probe in motion really what that area looks like. I strongly encourage that you do that, especially if you want somebody else to have a look at the images. So that's a little bit about nomology. Now, can I just say we discussed probes and we discussed the fact that probes are different frequency and we use different frequencies because we want to basically image optimize. Now, how do we image optimize? So I'm going to encourage you to look at this lower slide and I'm going to draw again. I apologize. So you have a probe which is in contact with skin with gel in between. And gel interface basically means that your penetration with these ultrasound waves is going into the brain. Now, we all know that when you use a certain frequency, there is a distance between the waves. Now, what is important is we want to be able to see objects in the brain very closely. Now, naturally, if you start using a high frequency probe, the resolution for objects over here is going to be quite poor. The resolution for nearer objects is going to be better. And then there's going to be an optimum place for resolution. And this is controlled by the focus button. So when you set your machine, you select your probe transducer, you select your frequency. And for a term baby or a near term baby, let's say we chose 8. So actually for 8, I am going to get waves that will penetrate throughout this brain and tell me about the anatomy well. And 8 will give me good penetration, but it might not get me good resolution for the superficial areas. On the other hand, if I decide that I'm going to use 10 for a preterm baby, again, I'm going to get better resolution because the frequency between the waves is going to be higher. The wavelength is going to be lower. And it just means that I will be better able to differentiate smaller objects between them because attenuation and tissue interaction with these waves is much better. So again, the kind of probes that we commonly use, we use the C58 in our setup. But if I want to look at meninges, I've got a G, and actually my linear probe takes a frequency up to 15, which is really good. So I can actually increase the frequency. I rarely have to need to use more than 12, unless I'm really looking at some of the vascular structures. But if you don't, and if you have a convex probe, an abdominal ultrasound probe, you're most welcome to use that. If you don't have that, then you might have to use a phased array probe. And just remember that a convex curvilinear probe is going to give you this view, but a phase array probe is unfortunately only going to give you this view. And that means that you'll be limited to a straight image. Now, this is really important, and this is where the concept of gain comes in. We know that when ultrasound waves penetrate the brain, as you can see over here, waves come back to the ultrasound probe. Now, waves interacting with the most superficial areas with a higher frequency will come back more quickly. So actually, from our perspective, not only will you have better resolution, but the images over here will appear brighter. On the other hand, ultrasound waves have had to pass through tissue to get to the back of the brain. More tissue interaction, more absorption, more attenuation. So what's reflected back is weaker. And actually, the brightness of the image at the back of the brain is going to be much poorer. So for that reason, really, we might have an image where we can see the superficial areas with adequate brightness, but we can't see the distal areas with adequate brightness. Now, potentially, we can then go back to using the gain button. But if you turn the gain up as a whole, what is going to happen is you are going to turn the brightness of this area up even more quickly, and this will appear brighter, and the back may appear bright to a point where it gives you good resolution, but this area looks too bright. And that is why we need time gain compensation. So, what is time gain compensation? It's a beautiful function. So, what time gain compensation does is we technically have got, so naturally, from our perspective, we've got this region over here. Gain is brighter in this region, gain is not so bright. And some of the objects that you see are actually very minuscule because it actually looks very dark in this area. So, what we can do is we can alter the brightness or the signal intensity of the returning waves in this particular area and make them stronger by using time gain compensation. And what time gain compensation basically functions as is these linear areas where actually what we're going to do is we're going to increase the gain here, we're going to increase the gain here, but we're not going to increase the gain here. And that means that the whole image is then going to appear more uniform and appear equally eco-lucent, eco-dense, or an area that looks unusually hypoechoic because it's dark or looks dark will then look eco-bright. And that will give you a better, more uniform image. And that is altered by this function. These knobs that you see over here, my apologies, they basically help. As I told you, they're linear knobs. So actually, when you're increasing them, you're increasing the brightness of the areas of the brain. These are the superficial areas of the brain. These are the deeper areas of the brain. So if I find that the deeper areas of the brain are not giving me really good images because they're quite dark, I will increase their acoustic signal return by actually turning the images to the right. Okay. Are you clear about the concepts of gain and time gain compensation? Is anybody confused? Because I will not move forwards if that is the case.
Yes, sir.
Ah,
Anybody confused?
I have a doubt.
Please.
Uh, I don't see these buttons in our machine. It's a Vivid IQ, the time gain compensation.
Yep.
Do you know if Vivid IQ has this option or if it is automatic?
Okay. So beautiful. That's a beautiful question. Are you using a GE Vivid?
Vivid IQ.
Yeah, you're using the Vivid IQ. Okay. So a simple thing is, when are you using a preset setting?
Yes.
Yeah. So simple thing that you have to do is you select your preset and it will give you an appearance of the brain. And your gain settings would have been set. But naturally, when you use that preset for a baby who's 38 weeks versus a baby who's 32 weeks, the same preset for a near term and a term baby, you'll still have differences in size of the brain, and you'll still have differences in the baby's echo texture because of the way the brain is, the water content, all of those things, the reflectivity. So that one setting will not suffice for all. The two ways that you're going to change it is you either press auto twice, and that will give you the optimized gain setting if that is the way your machine is set up. But if you find that you were using a frequency of 8 in a 32 weeker versus a 38 weeker who's 3 kilos, and the 32 weeker is about 1.5 kilos, then naturally, from your perspective, the same frequency in a 32 weeker will give you slightly poorer images, better penetration because you have a smaller brain, but less good resolution. So your best resolution will not be achieved. And for that, in your machine, because you don't have focus settings, what you will have to do is play with the frequency. And you might just have to press frequency and turn it up and down. But for the gain button, let's say that in a 32 weeker, you're using a frequency of 8, which naturally the waves will technically lose out. You will have better distal, deeper penetration in the 32-weaker smaller brain, the superficial areas will not look so good. So when you go back to your machine, your time gain concentration may have to be for the most superficial areas of the brain as opposed to the deeper areas. Now, the auto function should resolve that, but it might not. And you may have to still use time gain compensation in that setting. And the reason you might have to use it as well is uh, just to give you a really nice example. Sorry, just looking for my pen again. If your fontanelle is like this, as opposed to being that wide, then really what is going to happen is that frequency is going to give you penetration where you can only amplify signals based on the region of the fontanelle. Now, some machines have the ability, they've got what is called lateral gain compensation. So not only are you able to amplify images from the depth of the brain, but you can actually amplify images from where the waves are actually going laterally as well. Now, I know for a fact that our GE Vivid doesn't have lateral gain compensation, it just has time gain compensation. And experience usually says that if it's the fontanelle that's the limiting factor in that particular side, use the depth of the fontanelle, but don't hesitate in those situations if you want to see the deeper areas of the brain like the cerebellum to use the mastoid and the temporal views or the posterior fontanelle, which will give you better access. So there is a compromise when you're doing cranial ultrasound between using presets and using the manual mode. I would say that if your auto gain is working nicely and it's giving you a reasonable, good quality image, just relax. If you can clinically correlate and make the decision with it, that's good enough. But clearly, if you find that there is so much darkness over here in the periventricular areas, and we'll talk about those images, that it's actually under interpreting flare, then there's a real risk that you're going to make a diagnostic error. So optimizing images does not come with just a single image. Sometimes as you move from front to back while you're doing your images, you may have to optimize gain and lateral gain or tangential or time gain compensation for those individual areas as you move front and back. So time gain compensation is very important. Does that
Okay,
help?
thank you. Yes, yes, thank you.
Okay. Uh, Again, just a bit on the focus. So why do we have a focus? Because we want to obtain the best near field image. And I will talk about that when I talk about advanced ultrasound physics, is that really the advantage of having the focus button is it helps to concentrate those ultrasound waves which are diverging outwards. Because they're diverging outwards, you're getting poor resolution with the same frequency. You can actually get the focus button to focus them to the point of your interest. So you can lift the focus to superficial, you can lift the focus to the middle of the brain, and those are kind of things that are seen in old machines. Newer machines have the ability, as I've said, to optimize focus at every level, they do it dynamically as you move the probe. So you'll often find changes in both gain as well as resolution when you move the probe. And that is why it is really, really important. I want all of you to look at me at this point. So can you see me? Can all of you see me? We'll have a mannequin next time, but can you all see me?
Yes.
Okay.
Yes.
Actually, give me a moment. Okay. Can all of you see Gertrude over here?
Yes.
Yes.
Yes, yes.
Okay. So if this is your probe, okay, as you can see, then really from your perspective, when you hold your probe, I want you to practice holding the probe with your three fingers to support the base on the right-hand side. If you're right-handed, if you're left-handed, you're disabled. I'm really sorry. I apologize, but yeah, left-handed people are very disabled. Uh, Sue me. I think the most important thing from my perspective is having probe stability. Because for machines that tend to auto optimize at every level but gain functions, if you move too quickly, you will not get high quality images. Now, if you hold your probe here, you have no control over the probe. And in a small baby, capturing those 6 images that you need for the kind of coronal view, capturing those 5 images that you need for the sagittal view. The probe will just be all over the place. I want you to learn to hold the probe from the bottom. These two fingers, you can touch the fontanelle as you can see over here. You can press the fontanelle. That's telling me it's right-sided. But actually, once I've achieved my best image, this finger is going to stay here and it's going to support everything. We're not going to move. And what we're going to do is we're going to have very slow movements. Okay. And the game that we play is called statue. So as soon as I want my frontal lobes, okay, I've got me frontal lobes. There are no frontal horns visible. Okay. I can see some brightness. It's too bright. I need to reduce the gain. Auto. But can you see how my probe is not moved? But the baby might move. And that is also going to affect the quality of your images. And we'll come to how we can actually improve that. But it's really, really crucial from your perspective that you learn to practice holding the probe and controlling it. Uh, it it's very, very important for the brain. So how do we do that? So can you see how the probe is being held over here? So can I just say, this is not a criticism. My colleague who is doing the scans over here does better scans than I do. Absolutely better scans than I do. And she's an, you know, she's very good at what she does. She's holding the probe at this particular point, taking a corneal view, and she's kept her fingers front to back. And that's because she wants to control the motion of the probe. And really, she's got somebody who's controlling the baby's head, so she can actually do that. The advantage of holding the probe, as I've described, is that when you have the baby and the baby moves, it's very difficult if you have anterior posterior motion to control the probe. On the other hand, if you have the probe side to side with your fingers supporting it on the right hand side, then really you can control, you can keep one finger on the fontanelle so that you know that you're still on the fontanelle. And if the baby moves, really you're altering your probe in relation to that. So there's some benefits in being able to learn that way. That being said, that's easily overcome by what they're doing at this particular point. They're holding the probe and containing the baby beautifully. He looks comfortable over here. He looks inquisitive when you look at the slide on the right-hand side. He's kind of wondering, well, what exactly is happening over here? He's kind of quite thoughtful. Oh, are they looking at my brain at this particular point? But what you can see is now he's uncomfortable. Now, small amounts of pressure applied very hard will result in pain, and they will just compromise your images. But just a good overview of how you can get good control. Can you see how she's supporting the fontanelle with her fingers while she's holding the probe? This is the best way to hold the probe. She's doing it in an anterior posterior way because actually what she's doing at this particular point is doing sagittal views. These are corneal views with the marker to the right. Here the marker is anterior. So I would always encourage you to use your fingers to be able to feel, keep your level at the level of the fontanelle. Avoid pain, avoid pressure, keep it as loose as possible. Again, just probe markers always kept to the right when you're doing your corneal views. When you're doing your sagittal views, the probe markers always kept to the front. We'll talk about the other views as we move forwards. This is just, again, the posterior fontanelle. And again, you want to keep your probe marker on the right-hand side when you're doing the posterior fontanelle. You will always, when you're doing the other fontanelles, take both corneal and sagittal views. But I want you to learn to keep this simple. I need you to keep this as simple as possible. And really, what I need you to do, from my perspective, is learn how to take 6 corneal, 5 sagittal views, one view basically of the temporal region with the probe marker facing anteriorly, and one view of the cerebellar region with the probe marker facing towards the baby's face, basically in the direction. And really, that will help you see the cerebellum in adequate viewing, be able to measure it, see the cerebellar hemispheres. This view will basically be able to give you a very good view of the ventricular system. And if you can take those images along with whatever Dopplers are indicated, then what you are doing is a comprehensive scan. It's not an enhanced scan, but it's all you need. And we'll talk about the types of scans as we move forwards. But holding the probe, worst way to do it. Your actions will be wide, the baby moves, your probe will be all over the place. It will easily slip off this fontanelle. It will go onto bone because you're looking at the screen and trying to hand-eye coordinate. So have a look at me again. So when the baby's there and really I am holding the baby and trying to do the scan, I'm also looking at the screen, I'm image optimizing, and I'm using my left hand if I'm a right-handed person. Baby moves, I can't. But on the other hand, if I've got my fingers on the baby's fontanelle, actually, the way I've learned is I can tell I'm in the right place by the contact I have with the probe and the baby's head and the fontanelle along with my screen. Learning that hand-eye coordination is absolutely crucial to getting good images. So it's not just about the probe you use, it's also about the comfort in which you perform the scan, comfort of the baby, and eventually at the end of the day, it's really important for you to have good hand-eye coordination. Uh, Gel. So gel is a very important interface. It needs to be relatively uniform. Now, a simple example that I'd like to give you by showing you this last image is, if you press too hard, what happens is it squeezes gel out. You have more gel on this interface and less gel on this interface. So how will that affect your image? Well, naturally, because you have a better gel interface over here, and you are trying to look at the anterior part of the ventricular system. So if you look at the ventricular system as you move from front to back, you're really going to have the fourth ventricle in the cerebellum at the back. You're going to have the aqueduct in the middle, then the third ventricle. Now, the third ventricle might be visualized really nicely because you've got good penetration, because you've got good gel interface with a good frequency and amplitude of the waves penetrating through. So you have good resolution, and actually that falls in the best focal zone. But at the back of your image, because gel has come out, you're not going to have such good image. Your gain is going to be poor. The image is going to appear darker. You naturally run the risk of then having a poor quality image. But the bigger difficulty is when you try to improve your time gain compensation, it's not going to work because you don't have gel done uniformly or because you're pressing too hard. So just some really important aspects of the protocol. You want to achieve the best focal zone. That is automatically achieved in the new machines, but it's dynamic. And that's why your hand-eye coordination is absolutely crucial. Now, we've talked about the machine, we've talked about the probes, we've talked about holding the probes, we've talked about probe markers, we've talked about how we should hold the probes, how comfort is important. But really, what is very important is preparing the neonate and positioning. Any questions up till now? Very quickly, any questions? Feel free.
I'd like to just double check the views alloc if that's okay. So we need six coronal, five sagittal from the anterior fontanelle,
Yeah.
and
So
one
I
from the
know that Eamon in his last lecture talked about having five coronal views. There is a sixth coronal view that we basically call the Trishul view. That is something that is well described in Janet Rennie's textbook. So we'll talk about all of them. We'll talk about the six views that are done coronally, and we'll talk about the five views. We will be teaching you to do six coronal views.
Okay, thank you.
Okay. Okay. So, what is it and why is, I would say, preparing the neonate important? Well, it's because the better you prepare your neonate, the higher quality images you're going to get. Having said that, what is important is that you have aseptic technique. You wash your hands before you actually perform the scan, and you follow whatever your local protocols are. Swaddling is a very important concept, and we'll talk a little bit more about that, but so is the environment and ergonomics. So you are not going to be able to get an ultrasound machine into this area. There's not enough space. Sorry, for those of you, I swear a little bit, but my ultrasound machine has a very big ass, so it's just not going to fit there. And that, obviously, from my perspective, means that if I want to do a right-handed scan in this baby, it's going to be very challenging. So really, from my perspective, I'm going to have to change the way I do scans. I do have no space on the left-hand side either, because everything's kept over there. So one option is that I move this whole chamber where a baby is receiving phototherapy, which is not such a good idea. But there is another option, There is the option from my perspective of putting the machine here and actually holding and viewing the machine, but doing the ultrasound backwards. And a simple example that I'd like to give you is the view that you're going to see now. So have a look at me. Can all of you see me?
Yes.
Yes.
Okay. So instead of doing the scan like this with my right hand, having had the machine, what I might have to do is actually do the scan with my left hand in the front and have the machine outside of that space onto my extreme right. So you may have to, from your perspective, based on environment and ergonomics, have to actually change the way you actually do the images. The only other option from your perspective is to roll this incubator out a little bit, turn the neonate, and if the neonate's stable enough, one option is you can also get the neonate placed at 90 degrees, which will then allow you to do a right-handed scan if you're right-handed by just pushing this door down. So again, it's really important for you to consider machines, consider the stability of a baby. I mean, if this baby is high frequency oscillated on nitric, you know, not a good idea to touch the baby. Then really what you're going to have to do for minimal handling is basically do a left-handed inverted scan. And my colleague, Dr. Rajesh Sharma, is an absolute expert at being able to do this. He is amazing. Uh, Amazingly flexible is the word I'm going to use. Uh, I think the other challenge, obviously, is if you have big units with babies that are kind of crowded together but completely stable, you might then decide that actually it's easier for you rather than to bring the machine into very small areas to be able to do the scan if it's a screening scan by having certain positions in the unit where the babies can be bought. And I know for a fact that in Vietnam, where they have about 100 babies in a very small area, if the baby is stable enough to be able to do that, they do the images by actually sending the baby to radiology. They have to do it because they don't have any other facilities. They don't have a scanner on the actual unit, but they have a dedicated room on the unit where the radiologist then sits to be able to actually do that so that they don't have to take the baby all the way to radiology in a particular room. So again, you have to decide based on your ergonomics how best to do scans. We never move babies. We do our own scans. It's neonatologist performed. Containment is the second other important aspect. So can I just say that if you're doing this as a single person procedure without having somebody swaddle and hold the baby, good luck. Good luck, especially if you want to do an upside down scan like I'm demonstrating over here. Because actually, if the baby's moving all over the place, fighting, you know, if the baby's kind of hungry, sucking its finger, it's crying, it's upset, you are just not going to be able to get good quality images if it's waving its hand in the air trying to push the probe away. So really what I would always say is that for me this is a two-person procedure. I do not do cranial ultrasounds on my own, and it's a real challenge. I know, especially in UK units, that having nurses help you when they're so busy and so it's a little bit of give and take. It's really about, it's about bringing, and I would say having a little bit of a contract and kind of speaking to them about times that are convenient for them and then looking at the baby's stability. But I can't emphasize enough how important this concept of containment is. So again, just a few things before containment. I will always examine my baby, decide where I'm going to place the probe before I do my scan. It's giving me clinical information. So a lot of my colleagues will sometimes say, uh, they, it's busy and we help each other. That's the way we work in our unit. And they may want me to do a scan for a particular indication. And really, from my perspective, if it's an extremely preterm baby who they might not have seen that morning, well, if his blood pressure is in his boots and he's on 3 inotropes and his hemoglobin has dropped to 8, that's an urgent scan. That's a limited scan that needs to tell me whether he's got an IVH or not. It is not an enhanced scan. And really, how am I going to find that out? Well, if I examined him, I've gone through his notes, his history, I've gone through his clinical trends, I've felt his fontanelle, I've looked at his blood pressure, I know what his perfusion is like. Maybe he needs an urgent blood transfusion first. So small things like that, you always examine your babies, and that's always best done before you decide somebody has to contain and you have to start your scan, because otherwise you're missing out on vital clues. These are just really, really good examples of how containment helps. So, I mean, if you look at this baby over here, at this particular point, I mean, this is basically an abdominal ultrasound. I mean, he's really uncomfortable. And unless you have containment being done properly, it's not really helping because we're trying to get him to suck on something. We're also trying to kind of, I think what this baby really might need is some sucrose if you can give it to him. But what is happening is a lot of pressure is being applied, which is obviously painful. So again, having good ultrasounds again is just about contact. It's not about pressure. It's not about, you know, a real tendency that we have is to push the probe when we're doing our protocol for ultrasound. And again, this is a single person doing an ultrasound in the middle over here. Good luck. I mean, she's doing a great job, but it's really tough. Again, swaddling over here is not being done properly, but you can see that once the baby has been soothed. Now, soothing can be done by giving the baby sucrose, but we're just giving him something to suck on. So really, also, can you see how his hand is being contained towards the end of the video, just with the nurse using her fingers over there? So what is really important is that you need to practice containment properly. Here, no movements, the baby's comfortable, he's got a dummy in his mouth, he's had some sucrose. And this is naturally a very sick baby that you can see over here on sedation. Now, I have never needed to use sedation for a cranial ultrasound. And my recommendation is that really, if you're not adequately contained, you can do a lot of containment in a non-painful, comfortable way to be able to get your images. Using sedation in sick babies for cranial and lung ultrasounds, at least in my opinion, is not recommended.
Sorry,
Swaddling, yeah, we have a
sorry.
question.
Now, there is some people who write in WhatsApp. They want to come in, and
Okay,
they don't have access.
yeah, okay, I've let them in. My apologies, guys. It's really difficult once the talk starts. I will nominate somebody next time, but I apologize about those of you who, if you're going in and out, it becomes a little bit tricky. Just swaddling is the other way. So the nurses, and I've learned how to swaddle from my nurses. It is absolutely beautiful, but so is the way mom is holding the baby and giving the baby a feed. Now, can I just share some pearls of wisdom with you? There are things that work much better than sucrose. Sucrose is high osmolality. When you use it in newborn term babies, it mostly causes babies to choke and vomit. The other thing that I've noticed quite frequently with sucrose is that babies will suck on it for a while, but then really lose the taste and sensation, become quite upset. There's nothing that works better than being able to feed a baby before you do any procedure. So if you can feed the baby either during or before, personally, I prefer before, feed him half an hour before, let him be fully satisfied, let him swaddle up, keep him comfortable. For bigger babies, again, distraction can help. Now, a big challenge of doing a cranial ultrasound in this baby is going to be the hair. It's really going to compromise the image quality. I think you're really going to need, and this is an infant, somebody to help contain this baby. Again, play therapy for the infants really helps in that particular situation. But doing a scan, the best analgesic, in my opinion, is a good feed. It is the best analgesic and the best sedative. It works 100 times better than sucrose. So you can see this baby's nice and comfortable. You can do a scan anytime. He's not going to worry about it. Nice and content. Beautiful. Look at all that milk. Nice colostrum there. It is a two-person procedure for the reason I've already described. So just have a powwow with whoever's going to help you. Don't pull them off looking after another sick baby if the scan is just a routine scan that needs to be done. They may have time pressures and elements of work that they have to do. So just be kind. Always take a history and examine the baby before you start. We've discussed that. Now, what we're going to do is we're just going to talk about performing the ultrasound step by step. Okay? A simple approach, and I call it the 10-step approach. And really, what it basically involves is deciding on your scanning protocol, first of all. So you decide on your scanning protocol based on why and the indication for which you're doing the scan. Now, is this a scan in an unstable baby, which basically, from your perspective, needs to be done quickly to satisfy a point of care indication? Is he having an acute IVH at this particular point? How bad is it? What's the extension like? a baby who's basically bradycardic at this particular point uh, might be the wrong moment if he needs resuscitation to be doing a head scan. So again, clinical indication will vary. You might, from your perspective, have to resuscitate first, but it's really important that you understand the clinical indication, because for a baby who just needs a screening ultrasound for IVH on day one of life, you really probably need a comprehensive scan. And based on the literature, there are three types of scans described. There is an enhanced scan, there is a comprehensive scan, and there's a point of care scan. An enhanced scan basically means that you've done 6 coronal, 5 sagittal, at least 3 temporal, a perpendicular and a parallel mastoid, 3 posterior fontanella views, ACA Dopplers, middle cerebral artery Dopplers, and have noticed and seen the circle of Willis. That is a lot of images. In total, that'll come out to approximately 23 images. Now, that's a lot of handling for an extremely preterm 23-weeker where you're doing a golden hour scan, which is not necessarily the best thing. A comprehensive scan is really a screening scan. So again, what you're doing is you're doing your 6 coronal, 5 sagittal, you're doing 1 temporal, and you're doing at least 1 mastoid view, preferably parallel with the probe focused anteriorly, maybe just angulating a little bit above and below to make sure that you can see the cerebellum with cisterna magna and the fourth ventricle. So that, along with, it doesn't necessarily always need to have Dopplers. I might not need resistivity index or Dopplers in an extremely preterm baby when I'm screening for IVH or PVL, because actually there are no signs or symptoms to suggest to me that this baby has compromised perfusion. On the other hand, if this baby is shocked as well, and I'm worried about potential for steal from the cerebral circulation, I might want to do ACA Dopplers. Does he have a big duct? So again, a comprehensive scan follows your clinical indication, but will not have every image that has been described in the literature. And then a point of care scan is usually a limited sagittal coronal scan, often done an acute IVH in a crashing baby, or if you have a baby who's got acute hydrocephalus with raised intracranial tension, or a scan that's basically being done to kind of decide where you want to do the ventricular tap, which of the two ventricles is more dilated, really, where are you going to get your fluid out from, where is the ventricular margin close to the skin of the baby. Those are kind of point of care indications. But first step, schedule your cranial ultrasound so that it does not coincide with other procedures. Okay. So if you decide that you want to do your cranial ultrasound and the nurse wants to do a gas at the same time, no, it's not going to work. You need her help. But more importantly, the baby will be in pain and you're not going to get good quality images. Always ensure a second person is there to help you. So have a powwow, discuss when, how you're going to do the cranial ultrasound with whom, and make sure that the baby has got adequate sedation, comforting. The baby is swaddled where appropriate, has sucrose, or has had a feed. Second step, start the machine as we've already said. Enter patient details, select your transducer, optimize. Either choose a preset or choose and optimize based on placement of the probe on the baby's head. Now, before that, what you have to do is park the machine there, switch it on, enter the patient details. Ideally, in my mind, then wash your hands. Okay? Most of us will have also cleaned the transducer and the probe. So when you clean the transducer and the probe, you're cleaning the entire probe. So the entire probe, including everything that's going into the baby's incubator. We are also encouraged before and after to clean the motherboard. I don't necessarily clean the screen unless I have to touch it, if you have touch screen. But if you have touch screen, you're going to have to clean the screen as well, and you have to do it before and after. So really, what I'd say is that before parking, clean your machine, start the machine, enter the patient details, select your presets, go and wash your hands. Your transducer is now clean. Now put it on the baby's probe and image optimize. Baby's head and image optimize. Okay. Any questions? Any questions about that?
So, what to use to clean transducer, which will not damage that
Okay, so
transducer?
that's a really good question. So have I covered it? I think I have. So ideally in our setup, we use what we call as Cranial wipes. They basically have a concentration of a disinfectant and I will get you the name tomorrow. But it's good enough to be able to kind of cleanse the probe and the machine without causing any damage. Uh, I don't recommend using spirit, please. I know in Indian neonatal units, we use about 80% to 90% alcohol. Setting things on fire with electricity is not difficult in that situation, so please don't use that. But we use Clinell wipes. There are special, uh, what are they called? We use them for video laryngoscope cleaning. Forgotten. So specific wipes for ultrasound machines that are produced by a company, which I can tell you the next time around. Uh,
You can send that on WhatsApp when you remember.
Yeah.
After the meeting is over.
yeah, definitely. But guys, I'm not the only expert here. I have 24 other experts. What are you guys using?
Clinell.
You using Clinell? Anybody using anything else? There is a three-agent disinfectant specifically designed for ultrasound machines, which basically has a disinfecting agent with an agent that then cleans and prevents damage to the probe. I'll get you the name for it. It is £7 a sachet. It's not cheap. Personally, if you have Clinell wipes, that's the easiest thing to be able to use. Just important. Once you've kind of done everything before you place your probe, just feel the fontanelle. Just make sure you know how wide and open it is. Is this a fontanelle that's going to kind of hit the tip of my little finger? Because if that's the case, then I really might want to use a slightly different transducer. I might want to use, rather than the curvilinear, which, if this is the fontanelle size and I'm trying to use a curvilinear, might not give me that good an image. On the other hand, if I've got a nice wide fontanelle, I would always prefer using the curvilinear probe. We always, by protocol, start with coronal views first. I don't have a problem. You can start with sagittal views, but practice says you should start with the coronal views, identify the midline, and your marker should always be to the right. To confirm your marker is on the right with the machine, if you can see this little finger that you see over here, so can you see this little finger over here? If you push on it, and I will show you this when I'm doing a scan, if you push on it, your screen will basically indicate the probe is marker towards the right. It will show the marker, but it will confirm as well. It is not unusual about a decade back to have probes where markers were labeled wrong. I've not seen that happen in the last decade. So, but what we used to do in that situation is we just tap the fontanelle on the right side, confirm the probe markers also on the right, and that just ensures your orientation is completely correct. Okay, then the next step once you've got the probe marker on is image optimization. Like I said, if you don't have focus adjusted at every level, like the new Siemens GE sonocytes, uh, should have. And a good example is if you're using an old Fujitsu machine, you will have to adjust the focus. And as I said, the best place to have the focus is at the level of the interhemispheric fissure, just at the level where it joins the corpus callosum. I will point it out to you in images. You then adjust the image depth to 7 centimeters for a term baby, 5 for a preterm baby, auto gain or adjust gain settings, and then really, if you feel that you're not getting enough gain in the deeper part of the image because of attenuation, you might need to increase time gain compensation of the lower part of the image. On the other hand, if you only have a very low frequency for a preterm baby, then really the deeper images will give you better resolution than the superficial images. Again, you may have to increase time gain compensation in the upper half of the image. So these functions are step 4. Step 5, perform 6 coronal views. Quite simple. Have a look at my hand. Probe stillness is absolutely key. So when you look at my hand, somebody asked last time, is it sweeps? Yes. So I am getting my midline coronal view. I'm identifying, and we'll have a look at them, basically the corpus callosum with the lateral ventricles and the cavum septum pellucidum if it's present. And then what I'm doing is basically angulating anteriorly so that I can get to the frontal lobes, then basically the frontal horns, then basically lateral ventricles with cavum septum pellucidum, Then basically the trishul view or the trident view, as we've described. Then basically uh, the trigone with the cerebellum, and at the end, the occipital hemispheres. So that's 6 views that we have to obtain. Quite easy to do. So frontal lobe, anterior horn of the lateral ventricles, third ventricle, cerebellum, trigone, and occipital lobe. What are we going to see? So you're going to see orbits, frontal bone, and you're just going to see this frontal blush. So that is white matter. So you're going to see great white matter differentiation. If you have a baby with HIE who's got severe cerebral swelling, you might find the early phases, you can't see the frontal blush at all. And that really, the sulcal differentiation that you can see is absent. But really, as you move further back, what you start seeing is these frontal horns starting to appear. And again, you start seeing sulcal differentiation in term babies. You can still see the orbits. Then, as you move to the middle view of the third ventricle, you start seeing the cavum septum pellucidum with the lateral ventricle. Again, this is the interhemispheric fissure, as you can see. So I'm just going to take my marker to make it a little bit better for you. So this is the interhemispheric fissure. Again, frontal horns starting to appear in this particular region. Here, the lateral ventricles with the cavum septum pellucidum. Again, these are the temporal lobes, uncus of the temporal lobe. This is the interhemispheric fissure. And just for the purposes of quizzing in this particular situation, is this a preterm baby or a term baby? Anybody?
Preterm looks like
Preterm.
Sorry?
Preterm.
Yeah, it's
preterm.
preterm. Can you see how wide that
Preterm.
interhemispheric fissure is? So really, it's a really wide interhemispheric fissure that you see over here. Sorry, my apologies, Sylvian fissure. I'm running low on my glucose. So when you have such a wide Sylvian fissure, and again, you have a lot of extra axial space, then really, the question from our perspective is you don't see much sulcation over here, but you see a lot of sulcation over here. So this is a more preterm kind of view at this particular point. This is the Sylvian fissure. This is the interhemispheric fissure. These are the lateral ventricles. That's the cavum septum pellucidum. Okay, temporal lobes coming here. And then really what you're seeing once you go further back is the lateral ventricles, again, the Sylvian fissure with a Y. You may or may not see the cavum septum pellucidum in a term baby. It may have disappeared by this particular point. This view is also sometimes called the trident view, because if you see the cavum septum pellucidum in the middle, then what you basically see, and in a term baby you may not see it because it might have actually disappeared, is what is called like a trident. Aquaman trident. We also, for those of you who come from India, the goddess Shiva basically has what we call a trishul. So it's like a trident with which he slayed a lot of demons. So it's basically called the trident view. Now this is a view that some people tend not to describe in the literature, but really it is a view at the level where you can see the cerebellum really nicely. And hence it's a view that I really like because it's the only coronal view where you can see the cerebellum really nicely, as you can see over here. The next view that you see is really the view at the level of the trigone, and really what you're interested in is the choroid plexus and really the paraventricular areas. If you're looking for cystic periventricular leukomalacia, brightness, ischemic areas in a baby with HIE, then really these areas are very important. This area is very important, basal ganglia, thalamus. But for the preterm babies, the paraventricular areas tend to have a lot of ischemia and they'll look bright over there. And then really the last view that you want to see in the coronal view is the occipital view, where you have the occipital lobes and then you have a little bit of occipital blush. This is exactly what they look like. So again, frontal orbits, basically the frontal bone orbits. These small sulci that you see are called the sulcus olfactorius, but really this is the interhemispheric fissure. Then you have in your next view, and we don't quite have the frontal horns, we've gone a view further down, but you've just got the lateral ventricles appearing here with the cavum septum pellucidum. This is the Sylvian fissure, and really a good third view at the level of the foramen Monro. And this is actually the third view. It's not the second view that you see. It's kind of the third view that you see at the level of the third ventricle that they've described in this particular image. And then really what they've gone for is an image further back in the term baby. The reason why they've gone for this view in this particular image is they've skipped the frontal view, but then you have the trident view, as you can see over here. And again, really what you can see is a very nice cerebellar view over here, the thalamus. We then basically have the trigonal view. Uh, Here you have basically the splenium. You've got the choroid plexus, which is easily seen in the paraventricular areas. And you usually have this blush that you see more commonly in preterm babies. And then you have basically the parieto-occipital lobes, occipital lobes at the back with the sulcus parieto-occipitus. So these are kind of six views where you are missing the frontal view on this particular scan, but really the frontal view comes with the frontal horns and they appear there. The next step, basically from our perspective, is to rotate the probe 90 degrees. Now, some people like to basically review all their coronal images before they do the sagittal views. Personally, I think that's a lot of handling, and just the baby doesn't get a break because you then review your images, come back to the baby. I like taking all my images in one go, making sure I've got the requisite images. And then really from my perspective, what I like to do is basically then review all the images. So the sagittal view again, marker is anterior. You place and you always get your midline view. Sorry, my painting is just screwing up the images. But once you've got your midline view, you are then going to angulate the probe so that you can get the parasagittal view and the extreme parasagittal views. So you're basically angulating your probe. If you want to do your right side first, this way. And that will, so you'll get your midline image, then your parasagittal, and then your extreme parasagittal views. And then you want to do it on the left-hand side. Now, normally what I'd say is having a protocol of doing right from left really helps because it just means that you mark correctly. So I have just a habit. I will always do the right before the left. It just means that by habit, you're more likely to have your marker on the right side already done. And really, from your perspective, once you're in the coronal views, you only need, from your perspective, so just going back to the coronal views very quickly, to have labeled right once. But when you're doing your sagittal views, you have to be aware that you're going to have right and you're going to have left. So you are going to have labels twice. So I like doing the right before the left because I can then annotate appropriately. But again, this is just an example of how you are angulating to get really your midline, your parasagittal through the lateral ventricle, and your angled or extreme tangential parasagittal views. This is what it looks like from the top. So again, what you've got at this particular point is really midline cavum. Now, as you move from front to back, the definition of the cavum changes. If this is a preterm baby, what you've got at the front is the cavum septum pellucidum. But as you move to the back, if there is a remnant that's still present in the baby, it's called cavum vergi. And these are basically the lateral ventricles, and they'll have choroid plexus in them. This is what the views look like. So again, corpus callosum seen really nicely. You'll have the ventricular system in the center. You'll have the cerebellum with the fourth ventricle. You basically will be able to see the cerebellum with the cisterna magna at the bottom. You then have the pons, as Eamon showed you in the log. Most preterm babies, you have what is called a small prepontine cyst. It's basically a cyst that disappears. And again, this is a preterm scan because you can see how dilated the ventricles and bulky the choroids look on the lateral view. But really then what you're looking for is this sulcus when you're on your extreme angle tangential parasagittal view, because that is giving you the best view of the parietal occipital and temporal lobes. Anatomically, this is what it looks like. Again, as I said, cavum septum pellucidum anteriorly, cavum vergi posteriorly. You need to be able to demonstrate the entire corpus callosum in its entirety. So that's the genu, body, splenium. You need to be able to then trace the entire ventricular system. So this is the third ventricle that basically connects the ventricular system through the lateral ventricles down to the fourth ventricle over here, vermis of the cerebellum. This is the cerebellum. There are measurements for the cerebellum that you can do in this view, but traditional gestational based measurements are better done in the mastoid view. And then really what you've got is the parasagittal view. In the parasagittal view, you have important structures. You've obviously got the chorothalamic notch that was spoken about. You've got the choroid plexus. But really, what is very important is that in extremely preterm babies, one of the first sulci to appear is the sulcus parieto-occipitalis. And I will show you a lot of preterm scans, but people get really confused about the occipital lobe and really the parietal lobe. What is important is that at the level of the caudate and the thalamus, so this is the caudate with the putamen, and this is basically the thalamus that you see over here. And then you have the chorothalamic notch. And often hemorrhages in this region are basically called subemenymal hemorrhages. This is the temporal lobe with its uncus. But really what you've got is the occipital lobe, the parietal lobe, and the temporal lobe. Better seen as you move further out. And then you've got what is the sylvian or the lateral fissure with the insula. So these are common structures that you'll be able to basically do. Once you've got your views of the sagittal and the coronal views, the next step is to perform your Dopplers in these views. And a common Doppler that's performed is the ACA Doppler. We'll talk about Dopplers later on. I want you to focus on basically getting your mastoid views right. And really, this is what we call is the perpendicular mastoid view. It's kept with the probe marker up. And really what it's going to do is give you an overview of your cerebellum and a little bit of your hemispheres with the ventricles. But it's a really good view to be able to view the cerebellum, to be able to look for cerebellar hemorrhages. And one of our colleagues really asked, how do we label which lobe of the cerebellum when we're actually doing and we're performing only one mastoid view? Now, uh, so really what I'd say is that if you've got your marker up and you're viewing the cerebellum in that particular view, the lobes really don't necessarily get viewed as left or right. It's more when you move to the horizontal views. So you can angulate above and below to see the cerebellum. And this is really what you're going to see. Now, if you're doing this, and this is the baby's right hand, then the cerebellum that's close to you, and this is your probe, is got to be the right hemisphere. Does that make sense to everybody? The cerebellum that's away from you is going to be the left hemisphere. Is that clear?
Yes, yes.
Okay. I don't want you to have all these views. I need you to be able to see this view that you can see over here. I do not want you to become radiologists. We don't need to do that. Really, what we want to see is the cerebellar hemispheres with the sulcation where possible. Basically, the fourth ventricle. This is the cisterna magna. And really, this is really what you want to be able to see because this will give you cerebellar hemorrhage. It will give you the ability to measure and it will give you the fourth ventricle to see if it's collapsed, especially if you have obstruction at the level of the third ventricle communicating with the foramen of Monro. This is a view that I really like because it gives you a very nice view of the cerebellum again. And I like to keep the probe marker anteriorly. Again, you're keeping the probe marker so that it faces towards the baby's ear. And really, from your perspective, what you're getting again is really a good way to measure the cerebellar margins. And really, the distance that you measure with the cerebellum at these particular margins then correlates with gestation. But it also gives you the ability to be able to see the fourth ventricle again. these are the views that you really get. So this is the perpendicular view. Dr. Negrushu, you're drawing on my screen. It's okay. You're most welcome to. Uh, so really from
I'm
your,
sorry.
it's okay. No problems. Completely understandable. So what you see when you see the perpendicular view is you can see the sulcation of the cerebrum. It's a very vascular structure, so you can see how fine the sulcation is. Just be careful. I have seen people confuse this with cerebellar hemorrhage. But then you basically see the fourth ventricle with what is a little bit of choroid plexus. Now, this is a very magnified image. Now, if you angulate upwards, so just going backwards, so if you angulate upwards, so upwards kind of means towards the baby's face or towards the front, then really from your perspective, what you're going to do is you're going to see the back of the brain. And the back of the brain is going to be here. Whereas if you angulate forwards, you're going to see more front of the brain. So it is confusing. And my view is that don't get confused. Keep it simple. This is the image that we really want to see. And this is easily seen by angulating your cerebral hemispheres. Again, for the temporal view, you just want to take one view, and that is with your marker facing forwards towards the face. And really, once you've done that, the view that you really get is the ability to be able to see the ventricles. This is the third ventricle. These are the lateral ventricles. You just have the posterior fossa coming into view over there. Now, in this view, if you were to place your Dopplers, you'd be able to see the circle of Willis very nicely. And if you can see the circle of Willis, really, you have identified the most important vascular structures. Just a very good example of what you can see over here. So again, when you're looking at the temporal view with your marker forwards, you can see the third ventricle. This is basically communication between the third ventricle and the fourth ventricle is completely collapsed in this particular region. So we're not quite seeing it. And really, if you interrogate this a little bit more, what you would find is that there is a clot in the third ventricle, which is why the fourth ventricle is collapsed. So in this view, actually, what you can see is you can see the fourth ventricle with the cerebrum. So it's a really nice view, the temporal view, to be able to see the whole of the lateral ventricles, third ventricle, and fourth ventricle with the communication in between. And in preterm babies, so you can see the lateral ventricle, you can see the vermis, you can see the communication, and really the fourth ventricle is collapsed here because there's a hemorrhage over there. But you should be able to see the fourth ventricle, as you can see over here. I'm going to skip the posterior fontanelle for today, but really from our perspective, it's just angulating it above and beyond. And really what you're getting is, again, the trigonal view with the ventricles and then the occipital lobes at the back. Any questions about the views? So this presentation will be part of your chapter. All the drawings, everything is part of your chapter. There are GIFs in the chapter which basically show you how to do it. And as of Tuesday, you'll have a video basically showing all of this. So any questions about that? Okay, so I'm quickly going to summarize in the next 3 minutes, really what you do after that. So part 4 is the importance of really, you have taken these images, frozen, stored, and really if you've done your comprehensive scan, you've done your 6 coronal, 5 sagittal, 1 temporal, 1 mastoid view, you've done Dopplers if actually indicated. You have now reviewed and made sure that you've labeled these images properly. That's your 10th step. And then you store your images. That is your 10th and final step. This step-by-step approach is well described and has and will have an aid memoir as part of your chapters. You then sit down on your screen after having saved those images and then report after a second review of the still images or loops. That is the protocol for doing cranial ultrasound. Any questions? It sounds quite daunting. For our course, all we want to practice doing is really getting 6 sagittal views as described here. We want to get the frontal lobe, anterior horn of the lateral ventricles, third ventricle, cerebellum, trigone, and the occipital view. Again, really, we then want to rotate 90. We want to then get the sagittal views, which basically includes the midline, the parasagittal view through the lateral ventricles, and the angle tangential extreme parasagittal view, 3 views. Okay, you're going to repeat those 2 views on the right side. Always start on the right and go to the left. Label right, label left. You will only have to label once with your coronal views. You'll have to label twice. For those of you who are a little bit crazy, you can even label the anatomy if you like. God help you, it will take you, if you work in a 64-bedded unit where you have to scan babies, we can have up to 80, 90 babies. I think you need to be very cautious about how much time you spend. But really, these are what your parasagittal views look like. This is the anatomy again, well described, well described in the video. There's a video that summarizes all of this in 10 minutes. For the mastoid view, I only want you to practice taking this view by holding your probe up tangentially, which demonstrates the fourth ventricle and the cisterna magna, and then taking the whole of the cerebellum by turning your probe 90 degrees with the probe anteriorly, again, to visualize and measure the cerebellum. So these 2 views are really what you're going to take. At the end of the day, one temporal view, which basically highlights your ventricular system, lateral ventricles, third ventricle, and fourth ventricle, all in one line. That's all I want you to practice. Remember, term babies, you will not have the fontanelles of the mastoid view. The PF will be closed and the temporal view will be very difficult. But if they have hydrocephalus, you'll be surprised how these fontanelles actually open up and can be very useful in infants if they're open for seeing where the blockage is at the level of the ventricular system. So that's all we need to practice. And this is what we are going to peer review in this month. I just want you now, for those of you who are peer reviewing, bring whatever you can. If you can bring pathology, we're happy to look at pathology. If you were bringing normal, we're happy to look at normal. But we're looking at 6 candidates to share scans on Thursday before Abhijit's view on HIE. Because what we've covered so far is basically basic physics. We've covered the anatomy twice, and we've covered the protocol. And by Thursday, I need you to be completely familiar with this. I need you to put a probe on. Even if you're not doing probe kind of peer review, if you want, you can do individual peer review. We don't record. I just have a look at your images and help image optimized. I did that with 7 people for the lung ultrasound course. I'm very happy to dedicate time for you. I need you to be able to learn doing this, getting these views. By the end of the course, if you can do these 5 chapters and learn how to get these normal views and do ACA Dopplers, that's all you need to do. That makes you, I would say, that gives you the breadth of being able to do a comprehensive cranial ultrasound scan. Thank you very much.
Thank you.
Any questions? Time for 1 or 2?
Thank you.
8:30 now. Okay, next week's session will be half an hour of peer review and an hour where Abhijit will start talking about pathology. We're talking about term baby pathology. I will also be covering a little bit of advanced physics in my next session, just 15 minutes of advanced physics. Again, talking about time gain compensation, resolution, because actually as you get your images, we'll be talking a lot about how you optimize them, and you'll need to know those concepts. God bless you all, and I appreciate your bandwidth. This is not easy. I really appreciate your bandwidth. So God bless you. Thank you for being patient with me. Thank you for putting up with me. I just I just want you to put a probe on, please. Please put a probe on. God bless you. Take care.
Thank you.